Hello, this is Lydia.
And I'm Gretchen.
And we're going to be talking about autism. So what is autism? Autism is a group of neurodevelopmental disorders that are characterized by deficiencies in 3 domains: social interactions, communication, and repetitive or stereotypic behavior. And as you can see in the photo on your right, you can see that there are quite a few different disorders within the autistic spectrum disorder, and the ones I'd like to highlight are OCD, Asperger's disease, and ADHD, and ADD. And we'll be talking about ASD as a whole. So certain signs and symptoms of ASDs are those listed here, and as you can see, it's typically diagnosed at an early age within the first couple months of a child's life. The ones that we might be more commonly understood or know are those like avoiding eye contact and want to be alone, having delayed speech and language skills, getting upset by minor changes in their atmosphere, and then having unusual reactions to the way things smell, sound, look, or feel. So these are just a few of the many signs and symptoms that could be a part of those who are diagnosed with ASDs. So a little bit about the prevalence of ASDs. In 1994, the passage of the Special Education Classification of Autism was introduced, which provided more assistance to those with autism. This caused the prevalence to kind of jump in terms of data because more children were being diagnosed with the increase of resources and the increased umbrella of what autism or ASDs included, such as Asperger's disease, OCD, or ADHD. So, according to the CDC, about 1 in 68 children have ASDs, and males are more likely to have ASDs than females. So, almost 4 times more common in boys, 1 in 42, than girls, 1 in 189, according to the CDC. There is no difference in terms of ethnicity for those with ASDs, as was found in research that was looked into. The etiology for ASDs, there is no known single cause for ASDs. Commonalities among those with ASDs are abnormal brain structure or function. There is also a connection between ASDs and other disabilities that are diagnosed, such as Down syndrome. Those can both be common in the same child when found with ASDs. It's also a genetic etiology, so children who have either the Fragile X syndrome or untreated PKU are more likely to also have ASDs as well. So that's showing the genetic connection with ASDs. There's also the environmental aspect of ASDs. So heavy metals being ingested during pregnancy will increase the risk of a child developing autism, or one of the many ASDs under that umbrella. So those heavy metals can be seen in this next slide we have here with this graphic. It kind of shows not just the prenatal exposure, but also the postnatal exposure that could happen to increase the risk of a child developing autism spectrum disorders. So it's a nice graphic to kind of see how all the things can play out and influence that diagnosis. Now on to the pathophysiology. I will highlight 5 different theories that are out there. There's a lot of other theories, but these are the 5 that I wanted to highlight. First, neural connectivity. There's a connection of neural connectivity related to autism, but understanding whether it is over-connectivity or under-connectivity for the transfer of information is still unknown with research. So the research is pretty weak and not very strong in terms of agreeing on which of these is part of ASDs. The next is neural migration. So there's a decreased level of relin that can be found in those with ASDs. Ghrelin is an extracellular protein that contributes in events that are crucial for neuron migration and cellular positioning. So that is the second theory for pathophysiology. The third pathophysiology theory is the excitability of neurons. So the GABA receptor gene clusters or glutamate receptors can cause abnormal central nervous system excitability and function. So this is where the signaling is different in those with ASDs, which will have a slight connection to one of the other theories that I will cover in the next slide. Also part of this excitability neuron theory is that calcium signaling could also be a factor within this theory, which ties in to the nutritional aspect of this pathophysiology. So the fourth theory that I will cover is the dendritic function and structure. So ASD patients have been found to have increased numbers of long, thin dendritic spines. So this is something that is different in those comparative to the normal brains of those without ASDs. So that is something, and this will be covered a little bit further in the next slide with a nice graphic to kind of explain what that looks like. And finally, the mirror neuron system theory. So there are premotor and parietal cells that fire action potentials not just when they're in action or motion, but when they observe others performing similar actions. So these mirror actions of others and explains the social behaviors and skills of those with ASDs. This doesn't explain fully the neuron defects, which the other theories explained, but this is a more simple, not all-encompassing pathophysiology. So based on these 5 theories, the pathophysiology of ASDs is most likely a multi-domain disorder. Here is the wonderful graphic that I mentioned before, kind of showing, as you can see on your right, the difference between a normal brain and an autistic brain, and that difference in separation from the inferior olive and the trapezoid body there. So that's something that is kind of easier to see, to understand, and you can look at this further if you would like. So on to treatments. So for conventional treatments, here's a list of quite a few that are done for those with ASD. The few I'd like to highlight are the sensory integration therapy, which helps ASD patients deal with sights, sounds, and smells and how they handle those situations. Speech therapy, which is something we might all know for autistic children, and that improves their communication skills. And then medications, but there is no cure using medications, and there's really no cure for autism, but the medications can help to manage those symptoms. And CAM usage is very common in children with autism. A study found that 1 in 3 children diagnosed with autism had already tried some sort of dietary intervention. So the first CAM treatment we will highlight is the casein and gluten-free diet. So this diet excludes foods that contain grains such as wheat, oats, or rye, and dairy products for the casein. So this is a CAM therapy that targets the hypothesis that there is an incomplete breakdown and overabsorption of peptides with the opioid activity. And there were a few studies that were done when looking at this. All of them were fairly small populations, but they did find that it did have improvements in behavioral and cognitive factors, and it also increased their verbal and nonverbal communication. And then one study found that the removal of that casein and gluten from the diet improved the social interactions as well. And as you can see, it's not necessarily the safest due to the nutrient deficiencies in young population, and there was short-term efficacy within the few studies that I looked at. But we'll talk a little bit more about this later on. And here are two of the trials of the 5 that I looked at totally. And as you can see, they are from a small population, but there were positive results for those students.
So the next CAM therapy that we're going to talk about is melatonin. And about 80% of children with ASD actually have issues with sleeping, including sleep onset latency, was actually that is the amount of time that it takes to fall asleep once you go to bed, nighttime awakenings, and overall duration of sleep. And most children do have difficulties with sleeping. However, those with ASD are more sensitive to lost sleep and do not usually grow out of that behavior. Part of the reasoning for that is there is an endogenous melatonin, and that is it's not fully developed or used when a child is first born up until about 3 months of age. But as an infant grows, they usually get better and better at sleeping through the night. But for ASD children, that does not change. And the melatonin studies that we looked at were found to improve the sleep onset latency and the duration of sleep, but did not improve nighttime awakenings. So the thought process behind using the melatonin is that it would actually, by improving the sleep patterns, would actually improve the daytime behaviors for those children as well. Part of the reason why children with ASD are thought to have less melatonin production, it's because of the decreased levels of the acetylserotonin methyltransferase, and that is actually the enzyme that's needed for the production of melatonin within the body. So that endogenous melatonin that I talked about is controlled by the exposure to light, and it is independent of sleep time. And the improvement with the daytime behaviors, again, it's all related to that sleep. So the melatonin actually passively diffuses from the pineal gland to the blood and then is quickly distributed to the body's tissues. Melatonin research in ASD children has been going on since 1994, and most of the research has focused on controlled trials over the last 10 years. There have also been a couple of studies with uncontrolled trials. 2 of them are mentioned there on the slide. Again, they're relatively small studies, and that's one of the things that we've noticed with doing all of the research on ASD, is that the studies, although there might be a few of them, they were actually very limited in the number of subjects or patients that were used for each study. And with the controlled studies, the benefit was shown to improve the sleep duration and the onset sleep latency, and that was over using a placebo for those controlled trials. So the test that actually had the greatest results, or the most significant results for melatonin, is this retrospective observational study of 107 autistic patients using the melatonin. And the supplements were actually used for 13 months. The doses were administered 30 to 60 minutes beforehand, and the amount used was the 3 milligrams per patients that were under 6 years of age, and up to 6 milligrams for patients over 6 years old. And the one thing about the dose is that it was determined if they started using it and they didn't see an improvement or any difference in the sleep behaviors, that they would increase the dosage, but it never exceeded the 3 milligrams or the 6 milligrams for the patients based on age. And as you can see, there were some pretty positive results from that test. And there were only 2 that had worsened sleep habits or an unknown response, and 13% still reported problems with their sleep pattern. The next supplementation CAM therapy that we wanted to talk about is vitamin B6 and magnesium. And the supplementation intention with this is that this would improve alertness, better communication, and social interactions for the ASD children. It would improve their IQ and cause them to have fewer emotional outbursts and less self-mutilation. And what we found is that there is a combination of the vitamin B6 and magnesium proved to be the most beneficial way to use the supplements than to use either nutrient by itself or with a placebo. The mechanism of vitamin B6 and magnesium is unknown. However, they are thought to work in part by modulating dopamine metabolism. And again, there were several studies that looked at vitamin B6 and magnesium. I have just highlighted 3 of them here on this particular slide. But the dosage range for the vitamin B6 and magnesium was between 6 and 15 milligrams per kilogram per day. And as you can see, there was an improvement. In each one of these, there was an improvement seen with joint use to improve behavior. And if the supplementation was ever stopped, the symptoms or the behavioral issues prior to using the supplements returned. So ironically, with the one vitamin B6 and magnesium study, it was there were actually 2 double-blind studies that found the combination of the supplementation to not be beneficial. And unfortunately, there was no conclusive evidence as to why those 2 studies presented the conflicting results. However, I would like to point out that it's the dose of the magnesium that is significantly different. It's lower in these 2 studies. The one is 10 milligrams per kilogram of the magnesium oxide, while the other is 1.4 milligrams per kilogram of the magnesium. So unfortunately, we don't have any conclusive evidence as to why these presented different results. In terms of other promising treatments, though, for ASD children, you can look at folic acid, and it's for children that have a milder form of the cerebral folate deficiency, where they wouldn't have additional problems with neurological abnormalities such as slow head growth or psychomotor retardation. Fish oil is thought to relieve anxiety in autistic children, and glucosamine and multivitamin use are thought to improve the gastrointestinal issues in autistic children versus a placebo, and glucosamine actually works to improve chronic diarrhea. Now, all of these above mentioned CAM therapies need further trials before proving efficacy and also proving no harm to the patients. So overall, children with ASD tend to be higher users of CAM therapies, like Lydia mentioned earlier in the presentation. And those reasonings are because of the young age of those that are affected, the lack of overall effective treatments, and there is no great cure for ASD. And there's also a great concern about the adverse effects of using traditional medications. So when Lydia presented the gluten-free and casein-free diet, it does seem to be efficacious, but not for the long term. Again, it is part of the nutrient deficiencies that they're missing out on, and that could be important for bone health as well as the gut microbiota. And you want to keep that healthy, so it's best to stay away from that on a long-term use. And in terms of using the melatonin, it seems like this would be the best way to go for patients. They have the least amount of adverse side effects, as well as the best improvement or most significant impact on behavior and sleep disorders with ASD. Now, the vitamin B6 and magnesium seem to provide a good benefit with the 30 milligrams per kilogram of vitamin B6 and 10 to 15 milligrams of magnesium. And the studies do show conflicting results. However, children with ASD do have worsening behavioral symptoms when they are not taking the supplementation. And thank you. That concludes our presentation.